Dhruvi for that very kind introduction. And at the onset, I thank the whole team of Diabetes India for this opportunity. This is going to be a workshop on point of care testing in diabetes. And I tell you, we are doing a lot of point of care testing, not only in diabetes, but each and every field of medicine, from doing an optimal test for malaria, for TROP-T in emergencies, for NT-pro, BNP. So all these things are very, very popular. So similarly in diabetes, I'm going to talk about a very relevant point of care testings. This is the definition by College of American Pathologists, which defines POCT as test designed to be used at or near the site where the patient is located that do not require permanent dedicated space and that are performed outside the physical facilities of the clinical laboratories. I tell you, we can carry the devices from one clinic to another and do the point of care testing. This is the advantage of this particular process. The US FDA even similarly defines POCT A1C as a device used to measure the percentage concentration of HbA1c in blood, and the measurement of HbA1c is used as an aid in the diagnosis of diabetes and as an aid in the identification of patients at risk for developing diabetes. So we have a lot of even automated POCT devices which are available. We even have a recommendation from our own country. This is a very published data in 2019, which actually gives the recommendation for in-clinic POCTs for diabetes management in India. I have a couple of scenarios which we see in clinical practice. It's a very, very common scenario. We get patients referred for fitness of surgeries. This was before a cataract surgery, and the patient had done a lab test 2 days back, and he went to the ophthalmologist and said, I have come with the report, just I need my cataract surgery to be done. But a colleague of mine actually refers me for any cataract surgery in a diabetic for fitness. So he was like, just give me a fitness, I have the report done 2 days back and nothing else. But in our clinic, we have a routine that we do a blood sugar random in our clinic before giving them a fitness. The moment blood sugar was done, it was 436. And you know what the patient commented? He said, sir, ये डिबिया आपका खराब है, हमारा sugar 2 दिन पहले किया एकदम बराबर है. Then we did a HbA1c, it was 13.5%. And then we again repeated his urine for ketones and sugars. He was urine sugar 3 plus and ketones absent. Then I told him, you want to get operated, you get it operated. We are not going to give you fitness. So we have multiple reports which can be correlated at one time to suggest that this patient was actually keeping a uncontrolled diabetes and cataract surgery is not permissible. It's not safe for him. So this could be done in 10 minutes time. Can you believe this? So this is the advantage of POCT. Similarly, we had a 9 weeks pregnant lady, 32-year-old, was referred by a gynae colleague for management of her blood sugar. Now she was detected diabetic for the first time. She had a fasting of 180 and a PP of 270. Now she was in denial and not ready to accept her report. मेरे को आज तक कुछ प्रॉब्लम ही नहीं है, कुछ सिम्टम ही नहीं है, मुझे शुगर कैसा हो सकता है? Then she said, मैं तो दूर से आई हूँ, मैं तो जाऊँगी तो मैं कल फिर से नहीं आ सकती हूँ. And we did a blood sugar, HbA1c and urine. In 10 minutes time, we had a report. Blood sugar was 225, HbA1c was 9%, urine sugar was 1 plus and ketones were absent. She was diagnosed as a pre-existing type 2 diabetes. You know, the whole prognosis of this particular case changes the moment you do a HbA1c with a normal HbA1c and with a higher HbA1c. You can actually prognosticate this lady that you are very likely to have a congenital anomaly. So these are the real world advantages of doing a POCT in your clinic. And believe me, they are very, very simple today. So this is how it actually flows on. Patients, you can actually, you see, patient arrives for appointment, finger prick sample has been given, and they are readily available. I mean, the results are ready in minutes, 7 minutes, 10 minutes. These are the minutes how you get your reports. Like you get a TROP-I report in your emergency, ABG reports in your emergency. They are all what? ABG, this is nothing but a POCT. You have a small gadget in your hand, you take a arterial blood, and put it there in the cartridges, you get the report. Along with electrolytes you get a hematocrit. So a lot of data you get today by POCT's devices. So why they are becoming popular? Because of the compactness, fast and accurate, immediate decisions you can make, improve patient care, non-laboratory personals, you don't need a trained setup for it, and portability, as I said, from one clinic to another, you can carry them. testing compliance is poor in diabetic patients. This is also very, very important to understand that I heard a couple of lectures since morning. Patient एक बार आता है, फिर साल भर के बाद या 2 साल के बाद दोबारा आता है when they have some problems, not for follow-up. So you can understand how the compliance is for testing. So Indian health cost to treat diabetes reached over 73k crores in 2017. So this must have multiplied by now. So poor testing compliance leads to increases prevalence of complications in type 2 diabetes. And with the compliance with guidelines, the target is also poor. Only 26.7% of the patients diagnosed with diabetes meet the targets of glycemic blood pressure or cholesterol control. I've heard this in last 3 or 4 lectures, one by Dr. Bansi Sabu in the morning, later by Dr. Parekh in the other hall. So everyone is actually trying to quote upon that. But the important thing is the data which we are talking about today, how many of us are actually doing HbA1c for our patients? You know, the data is only 2 to 4% of the people are having POCTs in their clinic. Can you believe this is the data today? So we need almost 70 to 80% of the patient clinics to have POCT devices. And when they don't have a POCT device or a regular checkup centers, the patients don't undergo HbA1c testing. So next time I'll get the report. When is the next time you are prescribing medicines to this particular gentleman without doing an HbA1c, without knowing their status of HbA1c? So this is the real world challenge. The moment you have a point of care testing, the whole scenario completely changes in front of the patient. Like we have the example in front of you. So role of point of care testing in diabetes, if a patient comes to your clinic, you can do all these simple tests in 10 to 15 minutes time and your reports is in front of you. The patient feels very good. The patient is working in a bank, he takes a chutti for 30 minutes and 1 hour time, he comes to your clinic, he gets everything done and goes with a prescription. He feels very, very satisfied. The moment you tell him, come tomorrow morning fasting and we'll take your sample of fasting for lipids and fasting blood sugar and everything, sir, kal fir chutti lena padega kya? Then you will ask him, come in the evening for your reports and another consultation in the evening, and 2 hours later for your postprandial. Doesn't help today, you know. The compliance becomes very, very poor. And I tell you, this is what is needed today in chronic care. Services providers and technology should go hand in hand. And that is how patients' compliance and adherence is going to help. Because the next time follow-up, the patients, you know, you heard in the last lecture, patients आते नहीं, 50% patients clinic में follow-up नहीं करते. Why? Because of this cumbersome nature of follow-up. Patients है, अरे डॉक्टर के क्लिनिक में जाएंगे ना, फिर वहाँ 2 दिन 3 दिन का छुट्टी लेना पड़ेगा. You understand? So that type of mentality should not imbibe in the patient's mind. डॉक्टर के क्लिनिक में जाएंगे ना, 1 घंटे में सारा काम हो जाएगा. That comfort should be there in their mind so that they have a good follow-up. Opportunities for POCT in diabetes clinic is also very important. You can do a routine blood glucose self-testing. I remember when we started using glucometers in our clinic, I'm talking about 20 years down the lane. People used to say, these are not very, very reliable, go to the laboratory and get it done. But when you used to pick up hypoglycemia and correct it immediately, then they used to accept that a particular device is good. So that is how the opportunistic people are in it. The moment you say the blood sugar is 500, this is not a good device, go to the laboratory. The moment you say you have a good reading, everything is fine. Similarly with today we do ambulatory glucose monitoring. You get the data is good, the device is good. You don't get good data, the device becomes bad. Blood glucose is done by capillary method, precision, accuracy, and user acceptance. We have Dr. Amit here to talk on this a little later. Structured SMBG, precision is there. In repeatedly, there is a data from One Touch which says that the variation is very, very less. In the lower values, the CV is less than 5% and the standard deviation of less than 5 milligram per deciliter. And in the clinical accuracy study, 100% of measurements were with less than 75, were between plus minus 15 milligrams. So it's almost as good as the laboratory data. And 99.6% of measurements with more than 75 and less than 200 were within plus minus 20%. So it's very, very accurate today. And the select simple BGMS met all criteria for precision, system, and user accuracy, was easy to use and was well accepted by the patients. And we all know the advantages of SMBG. I'm not going to talk much on that, but It improves the blood glucose control. It has become one part of almost all the patients on insulin therapy in pregnant ladies, in type 1 diabetics, because less time is lost between recognizing symptoms and confirming blood glucose levels. 5 seconds. Patient gains independence in diabetes management and helps patient to learn and understand decision making process. Similarly, urine testing is very, very simple. We don't do much today, but we do use a ketodiastics. I always ask my patients to use a ketodiastics who have a poorly controlled diabetes to look for ketone bodies, especially in type 1 diabetes. And the limitations and the uses are, it is significant in diabetes mellitus and renal glycosuria, but today patients are getting drugs like SGLT2 inhibitors where you can have falsely positive urine glucose with normal blood glucose values. Limitations are interference, reducing agents, especially vitamin C. Today in COVID time, every patient is taking 2 to 3 tablets of vitamin C, ascorbic acid, 500 milligram, immune booster drugs, and that is how you get falsely positive urine sugars as well. POC HbA1c is very, very popular today. I am sure most of us are using it very, very comfortably, very easy to use. You take a sample, you examine a patient, you do everything. By the time everything has been done, your reports are ready in front of you. Ready to use reagent cartridges that can be inserted straight into the analyzer. Blood samples are added directly. No need for pre-mixing or pipetting. Minimizing the number of steps in the procedure reduces user error and standardize results by eliminating any variation introduced by different operators. We usually use this boronate fluorescence quenching technology in Athenion LR meters, which we use commonly in our clinics. And it takes 3 minutes is the assay time. 1.5 microliter is a sample volume. You can understand very little blood is being needed. Whole blood samples are used. Configurable measuring units. Measuring range is 4 to 15 HbA1c. If you have HbA1c more than 15, it's like high, like your glucometer, right, more than 15%. But the good part of this meter is if your hemoglobin is less or your hemoglobin is high, it detects it and tells you that your hemoglobin is less, so it doesn't give you an HbA1c value. You can send the patient for anemia check and you'll get the report immediately. Similarly, for higher HbA1c, higher hemoglobin values like more than 15 or 16, it picks up and says you have a higher hemoglobin values. This is how it looks like the Athenion 2, the newer one. And the good thing is it actually takes care of not only HbA1c, albumin creatinine ratio, the lipid panel, the CRP panel. Recently, they are going to come up with the anti-pro-BNP panel as well. POCT leads to better HbA1c reduction compared to lab, both in long term and short term. And we are experiencing in clinics as well. Patient just comes to get their HbA1c done in clinics and they just move on that the HbA1c is good. They enter the clinic, get their blood tested and move on. So that is the type of advantage we have with this point of care centers. And use of POC testing for A1C provides the opportunity for more timely treatment changes. Today, the ADA suggests that if a patient is having a good control of diabetes, at least 2 to 3 HbA1c should be done, 2 minimum HbA1c should be done. And if a patient is having a poorly control of diabetes, every 3 months he should undergo a HbA1c till his levels, targets are been achieved. So that is the type of recommendation which is coming up. Similarly, for microalbuminuria, we have a POCT device. The same device, we have a different cartridges we can use for microalbumin. We have a test strips as well, which are available. This we used to do when we were doing post-creation in our hospital. We had these strips in our ward, and we used to routinely follow this. Similarly, we have from Siemens the Clinitec microalbumin reagent strips. So the important thing is the ACR test strip showed high sensitivity, specificity, and negative predictive values, suggesting that the test can be used to screen for albuminuria in cases of pre-diabetes and diabetes. You get an idea in front of you. You can immediately tell your patients to take care of it. You can repeat it after 3 months. Even the ADA says you should have 2 microalbumin positive in 6 months' time to actually say that this patient has got nephropathy. And you should rule out UTI. 1 or 2 minutes, yeah. Similarly, for lipid panels, we use these meters like point of care devices. The Cholestech LDX is the one which we are using it. and it comes with a very handy device. And the lipid profile can not only be just a lipid profile, you actually get all these readings incorporated, and finally you get a CSD risk calculated in percentage of algorithm by Framingham Heart Study. So this is another advantage with this. Similarly, we do a ketone test. The urine dipsticks test is very, very popular. We commonly use this. The ketone bodies detection is also has limitations. Like significance is like diabetes, ketoacidosis, prolonged fasting, and even patients on SGLT2 inhibitors can have ketones positive. Euglycemic ketoacidosis is known with SGLT2 inhibitors. The limitations, as we discussed, are interference. We have a device to look for even blood ketone bodies, which is not commonly used. Only when you are using this meter, you can use this device. What to expect with ketone meters? The sensitivity is again very, very good. The accurate results in 10 seconds. And people you have to be cautious in people who are on low carb diets, and experts have not reached an agreement as to what high is too high. So these are the benefits obtained by utilizing POCTs, operational benefits, clinical benefits, economic and patients benefit as well. And POCT improves patients and healthcare providers' communication and collaboration in diabetes management. They understand right in front of you. The important thing is a very transparent system. Patient sees in front of them that their blood has been utilized and the report is in front of them. That's the most important thing. In the bigger laboratories, they feel sometimes that sample got mismatched and it's not possible. My fasting was 110, my PP was 180, how can the HbA1c be 9 and 10? So again, that is an advantage with POCT. There are some issues with POCTs, but training has to be good. So to summarize this, simple and accurate POCT can help overcome barriers and reduce compliance with testing frequency. And this has become a holistic approach to diabetes care in many countries and many healthcare organizations. POCT can improve patient satisfaction, foster a stronger patient-provider relationship, and motivate patients to be more involved with self-care. Implementation of POC testing also helps to elevate the burden of diabetes on providers by streamlining operations and creating efficiencies within the practice. Accuracy and precision of test is still a challenge, hence utility of POC as diagnostic purpose needs further validation. Like for glucometers, we say no, you can screen a non-diabetic person with a glucometer, but when you have in doubt, ask them to go to a laboratory and do an OGTT or a 75 grams glucose tolerance test to actually pick up for diagnosis of diabetes. Similarly with HbA1c in POCT, if you have someone with a HbA1c of 9 or 10, you need not even confirm it. But someone having a HbA1c of 6.6 and 6.7, you can get a second test by HPLC method, which is the gold standard to confirm it. So that is the type of validation we need. But improved clinical outcomes increases the recognition that testing plays an important role in the management of diabetes and related complications. So I thank each and everyone for their patient listening, and I thank the organizers for this opportunity. Thank you.